Three, two, one. We are live now, sir.
Okay. Sir, shall we start?
Yeah, please go ahead.
Okay, sir. Good evening and warm welcome to the episode 14, Blood the Life Savior, a series dedicated to the exploring the complex hematological conditions through expert discussion, real world case insight, and academic collaboration. Each episode, this series has been a step forward in strengthening our understanding of bleeding and hematological disorders that often challenge clinical practice. Today's episode brings to you yet another fascinating topic, that's acquired hemophilia A. We are honored to have our academic collaboration with our, as well as today's, there's a Belvedere Church Medical College Hospital, Trivela. So today a session that will start right from 7 o'clock till 8 o'clock, and we are very well blessed with that. We have our course director, Dr. B.G. George, and Dr. Matthew Joseph, sir. They are taking care of this web series. And what to say more about the both the stalwarts of India, of hematology. So as far as to give a small introduction of our course director, Dr. B.G. George, he is a professor and head of clinical hematology, CMC Vellore. And sir has more than 296 publication and prestigious national and international publication, and contribution in 6 book chapters and publication focusing on the hematology and stem cell transplantation. And very recently, we have got a new sir is going to be as a director of CMC right from the 1st of April onward. So from my side, sir, heartiest congratulations to you. And further to this, our second course director, Dr. Joseph John, a professor and head of Department of Clinical Hematology, CMC Ludhiana. Sir has more than 30 international and 38 national publications, part of 7 books in prestigious national and international publication, and one copyright protocol on the near miss and error disclosure. Further to this, sir is a principal investigator in more than the 20 clinical trials. Welcome to you, sir. And with this, nothing say much more to these two stalwarts of this hematology. And over to Dr. B.G. George, sir. So, sir, please take from this head, sir.
Thank you. Thank you so much. So today we're going to be continuing our series. It's been going on for a year now, and we have Dr. Chepsi and his team from Believers Hospital who's going to be talking about acquired hemophilia A. So I will now hand it over to Chepsi to please go ahead with the presentation.
Thank you, sir. I'll thank you for the opportunity that you've given as a team. This is our first foray into this sessions that is being hosted as Blood Savior. So today, Dr. Sudhir will actually discuss on a rare disease, but quite common in a hematological practice, where patients might present with isolated APTT prolongation, might come with unusual bleeds, and often it might be critical. So they will discuss 2 cases showing who gets it, the associations of age with acquired hemophilia, and then the typical bleeding pattern that is seen in such patients, and what is the best approach to a diagnosis, and in terms of management, the goals of managing in terms of acute bleed as well as eradicating the inhibitor. So I think I won't waste much time and hand it over to Sudhir to take it from here.
Good evening to all esteemed dignitaries present in the forum. I'll be starting the presentation. We are going to present regarding two different presentation of acquired hemophilia. This one slides visible also.
Yes.
Okay. We'll be seeing two presentations. The first one is a 56-year-old gentleman who initially presented with complaints of reddish discoloration, swelling on the left thigh, size of around 10 into 8 centimeter, and over right forearm of size 8 into 8 centimeter. It's been there for the past 10 days, which was spontaneous in occurrence, which is not associated with any trauma. He also had a complaint of fever for 3 days and a breathing difficulty for 1 day, which was the reason he presented to our institution. He had a past history of similar complaints on the right leg for which was 1 month back, which was also spontaneous in occurrence, and it is also not associated with any trauma. He had no previous history of epistaxis, petechiae, purpura, or prolonged bleeding from minor wounds, or any bleeding gums, melena, hematochezia, and hematuria. He also had no previous history of joint swelling or any discoloration over the joints or pain in the joints. No history of prolonged bleeding following dental procedures. Patient also had a previous history of hematoma formation and discoloration following venipuncture during the previous trailing 3 weeks. He had a history of Ayurvedic medicine intake for diabetes mellitus for a duration of 1 month before the onset of this current presentation. He had no other significant past history, no surgical history, and there is no bleeding history in the family. The course in the hospital, patient was initially admitted under general medicine. He was treated as a case of community-acquired pneumonia, and all routine investigations were done, which the peripheral smear showed normocytic normochromic anemia and thrombocytosis. Since the patient presented with hematoma, bleeding time and clotting time and coagulogram investigations were done, which were normal. The coagulogram showed a raised APTT values of 66.1. And because of that, the hematology consult was sought. We had asked for an APTT mixing studies, which showed only partial correction of 45.8. So we were thinking in terms of any inhibitor and a possibility of a factor 5 deficiency or any inhibitor presence. So we asked for an factor 8 functional assay, which came as 5%. Simultaneously, workup for possibility of an acquired hemophilia was also started. Lupus anticoagulant was done. ANA was sent, which came as HEP2. Lupus anticoagulant was negative. ANA was HEP2 1 plus and nuclear speckle pattern. Profile was negative. In the meantime, patient had hematoma formation in all the venipuncture site, and patient had profuse bleeding. So ideally, there was no IV line which could be secured. So yeah, by the time we had also sent for an inhibitor assay, so we were waiting for the inhibitor assay to be released. So in view of profuse bleeding, and we had given an injection emicizumab 150 microgram, which was given subcutaneously, following which a PICC line was secured, and following the administration, bleeding also subsided. By the meantime, we also received the factor VIII inhibitor assay, which was 140.8 Bethesda units. Simultaneous workup, the diagnosis of acquired hemophilia A was made, and etiology workup was also started. The malignancy markers CA19-9, AFP, and CEA and PSA was done, which were normal. And PET-CT was done to see if there is any occult primary. And the patient had ongoing blood loss in terms of hematoma, and in view of severe anemia, PRBC was transfused. And definitive treatment in terms of immunosuppression was started with prednisolone at 1 mg per kg. And injection rituximab 100 mg stat dose was given, following which there was no further new onset bleeding manifestation was noted. Even after a sampling also, there was no new onset hematoma. Patient was discharged and planned to continue prednisolone and weekly Ritux doses on OPD basis. So this was the investigation trend which we noted. Patient, we received it at late night on 3rd of March 2025. At that time, APTT was 65. Hematology consult was salt on 5th, and we had asked for mixing studies which showed 45.8 and factor 8 functional assay came as 5%. Uh, by the time we had also received, the patient also received emicizumab 150 mg for to control profuse bleeding, and we received factor VIII inhibitor assay, which came out to be 140.8 Bethesda units. Prednisolone was started at 1 mg per kg on the same day, and following which the subsequent APTT showed improvement. On 12th, it is 33.6, following which the first dose of Ritux was given, 100 mg, and patient was planned for 100 mg for weekly once for 4 doses. And subsequently, once that he had no further bleeding episodes or hematoma formation. And during OPD follow-up, since the APTT was improving, we had started to taper the prednisolone also. On April 11th, APTT was 29.6 by the time he had completed 4 doses of rituximab, and prednisolone was gradually tapered, and he was continued on 10 mg OD. He had a revisit on April 25th. At that time, APTT was 31.2. He was still on prednisolone. He had lost follow-up for a duration of 4 months, and he again revisited us on August 1. During that time, APTT was checked, it was 27.18 normal. And we had again asked for an factor VIII inhibitor assay, which was done on 6th/8, which is negative, which is less than 0.5 Bethesda units. Follow-up is the patient was tapered on prednisolone over gradually over a period of 6 weeks, and he had no any further new onset bleeding manifestations. And now we'll be discussing about the case too. This lady initially presented with an mucocutaneous bleeding rather than a hematoma. She's a 54-year-old female. She presented with complaints of bleeding gums for a duration of 3 days. She had complaints of generalized tiredness and easy fatigability. She had a previous history of menstrual bleeding in 2024 for a duration of 1 month, continuous profuse bleeding. She had used 6 to 7 pads per day with passage of clots. She had consulted a local gynecologist, and she had prescribed Trenexa and norethistron, following which the menstrual bleeding had settled. By that time, she was evaluated for abnormal uterine bleeding and found to have an endometrial thickness of 15 millimeters, and following which she had been taken for a total abdominal hysterectomy with bilateral salpingo-oophorectomy. And she didn't have any previous history of epistaxis, petechiae, purpura, or prolonged bleeding from minor wounds, or no previous history of melena, hematochezia, or hematuria. No history of joint swelling or any discoloration over the joints or pain, associated pain. No history of any swelling over muscular regions. No history of easy bruising over trivial trauma. No history of prolonged bleeding during previous dental extraction or from minor wounds or during previous surgeries. Like I said, she had a surgical history of total abdominal hysterectomy for abdominal uterine bleeding. No prolonged bleeding, or there was no difficulty in managing the bleeding during the perioperative procedure period. And she doesn't have any significant past history, and no bleeding history in the family as well. The patient was initially evaluated as in the OPD basis. Routine investigations were done which showed mild anemia, normocytic, normochromic. Because of the coagulogram showed APDT values which were increased 63.78. We had asked for mixing studies which showed partial correction and which raised the suspicion of an acquired hemophilia. By the time inhibitor screen also came as positive. Factor VIII functional assay was less than 1%. Factor VIII inhibitor assay by classic Bethesda assay was 18.4 Bethesda units. Patient was started on tranexamic acid for bleeding gums, which was settled the next day. The etiology workup was also started. Autoimmune workup was negative. The patient was started on immunosuppression with prednisolone 1 mg per kg was started. This is the investigation chart. We received the patient in OPD basis on 19th of November this previous year. APDT was 66.19. Mixing studies showed partial correction, which is 41.6. Fat rate functional assay was less than 1%. Tranexamic acid was given for bleeding control. On the next day, we received a fat rate inhibitor assay, which was 18.4. In view of that, immunosuppression was started with prednisolone 1 mg per kg. Subsequently, she was followed up in OPD basis. The following of follow-up APDT values on 18th of 12 showed 44, and the fat rate functional assay has increased slightly, which is 12.66. Prednisolone was still continued. And again, she had a visit in 19th of Jan 2026. At that time, the APDT was 27.3, and she had completed 6 weeks of prednisolone, so we started to taper the prednisolone dosage. Follow-up, she didn't have any further mucosal bleedings, and she was continued on steroids. She again visited on 18/12. Like you said, she was continued on steroids, and we had planned to taper. And again, on 19th of Jan, she had no further bleeding episodes. APTT is normalized, and prednisolone was tapered to 40 mg OD. Thank you, sir.
So, Chipsy, what I would suggest is
Yeah.
please go ahead with the discussion, and
Yeah.
then we'll go ahead with the questions after that.
So fine. So Dr. Akash and Dr. Minu will lead the discussion on the management and the laboratory assays which are needed in such a setting. So I'll hand it over to Akash and Minu.
Hello, sir. Just give us a moment. We're just having some logistical issues here.
Yeah. So while it is loading, at least what we were trying to highlight is that not everybody might have a chromogenic assay like the major centers. So at our center, we still use this clot-based assay only. So there are limitations to detecting the activity once you give emicizumab, which is what Dr. Minu will breach upon, and Akash will also explain in case of if you don't have bypass agents available, what are the other options you can use. So the two goals of management in an acquired hemophilia remain broadly: one, we need to control the bleeding, and two, we need to make sure that the inhibitor gets eradicated. So in the past, the approach used to be that you try and hasten the eradication of the inhibitor as much as you can by using immunosuppressants a lot. But with the advent of emicizumab, more and more understanding has now emerged that as long as you can settle the bleeding, you can be lighter on your immunosuppressants and avoid the infective risk and the thrombotic risk that comes with bypassing agents, and use products if available, even though we recognize the cost involved with it. So I think that's how we are taking the discussion forward. Akash, you're good to go.
Good evening, everyone. I would like to thank Dr. Biju sir and Joseph sir for giving us this opportunity in this joining in this discussion. Is my slides visible?
No, ma'am, not right now. Your screen is visible. Your whole screen is sharing.
I don't think the slides are shared as it.
I mean, the Zoom screen is only getting scared. The PPT is not getting shared. Okay, so while the slides are getting loaded, just for the benefit of, yeah, okay, it's come.
Yeah, just put it onto slideshow. Yeah,
Yes.
good.
Sorry for the delay. Good evening, everyone. So coming to the discussion part, we have seen two patients who had like adult patients who without any prior previous histories, significant histories in the past, they presented with a mucocutaneous bleeding of short duration. With when we evaluated, we have found that the CBC with peripheral smear all were normal. So on further evaluation, we have the coagulation parameters showed an isolated prolonged APTT. So we went ahead with the APTT mixing studies. So on doing the APTT mixing studies, we have noted that there was no correction. So and the screening for the lupus anticoagulant was negative. So that means like there could be an inhibitor which is like against the factors. So factor specific inhibitor is a possibility here. So this is the inhibitor screening which can be done, which is usually the same like a mixing study. Here what we do is like we use a normal plasma with the patient test plasma. We mix equal volumes of both and then we incubate for at 37 degrees Celsius for 2 hours. And we keep it aside. That will be our tube 3 and another tube will be a fresh mix without incubation. So and then we proceed with APTT. So if the difference between the fresh mix and incubated mix is more than 10 seconds, that suggests there is an inhibitor which is a time-dependent inhibitor. But if the difference between the fresh mix and the incubated mix is less than 10 seconds, there is no time-dependent inhibitor. If the inhibitor screen is positive, then we will proceed with the inhibitor assay. So this is the interpretation of this screening assay. So if you note that all the tubes are normal, then the interpretation is normal. And if you see that if the tube 3 and if both the tubes, that is like if you have a incubated mix and the immediate mix, both are prolonged, that means like there could be a possibility of an immediately acting inhibitor. But if the tube fresh mix is normal and while the incubated mix is prolonged, that means like there is a time dependent inhibitor. So usually the factor 8 inhibitors are a time and temperature dependent inhibitors and their common target will be the A2 of the factor 8. Usually in an acquired hemophilia, we have the type 2 inhibitors. They follow the second order kinetics. We can see from the graph that they don't follow a linear pattern. So that means that there is incomplete inactivation even if you have a high inhibitor titer. You don't get a complete inactivation. So that will be a complex kinetics. And usually this is what is seen in acquired hemophilia, while you get a type 1 in a congenital hemophilia who develops inhibitor. So the if your screening test is positive, then you proceed with the functional assays. There are two type of assays, which is a clot-based assay and a chromogenic assay for assessing the inhibitor assay. So usually your the functional, I mean the factor 8 assay. You have the Bethesda assay and a Nemagen Bethesda assay, which is a modification of the Bethesda assay, and a chromogenic Bethesda assay, which is when you use emicizumab. So coming to the Bethesda assay, you assume like one Bethesda unit of the inhibitor is defined as the amount of antibody that will inactivate 50% of the added, the plasma factor 8 which you have added, the 50% will be inactivated by the one Bethesda unit of the inhibitor present in the patient plasma after 2 hours of incubation at 37 degrees Celsius. So here for conducting the test, either you can use a commercially prepared plasma or a in-house calibrated pooled normal plasma where you assume that your factor 8 activity will be 100%. And the time of incubation will be 2 hours and then you proceed with the residual factor 8 activity. So which you can do using the one stage APTT based assay. You can use either the human or the porcine factor 8 for this test. So this is a summary of the Bethesda assay. Here your limit of detection will be 0.05 Bethesda units, and more than 0.6 Bethesda units will be considered as a positive test for factor 8, and while for factor 9 it will be like more than 0.3. So here you will have a diluted patient plasma, pooled normal plasma, and a buffer. So your buffer with pooled normal plasma will act as your control, and you have a serial dilutions of the patient plasma, and the pooled normal plasma will be there. So initially in the one tube, you will mix the patient plasma and the pooled normal plasma 1:1, and then you will keep it aside, and then you will do the serial dilutions using the imidazole buffer. So this will be serially diluted till 1 in 1024, like this serial dilutions. Initial test, you take half of the amount from the first tube, and then you mix the same amount of the imidazole buffer, and then you serially dilute the samples. So you have a pooled normal plasma with the buffer, which will act as your control, and you have a pooled normal plasma with undiluted test plasma, and also you have a pooled normal plasma with a serially diluted test plasma. So you incubate all these tubes at 37 degrees Celsius for 2 hours. And then you run the factor rate assay in all these tests. At the end of 2 hours, in all these mixtures, you will do the factor rate assay. So you will get the values like this. This is an example. So usually you consider that your control plasma, you should have 100% activity, but with time there can be a reduction in the factor rate activity. So your control is showing only 90% of the factor rate levels. So in the other serially diluted, you can see that there is a gradually increasing factor rate activity. So you will select the dilution which has almost as close to 50% of the residual factor rate assay. You will select that specific dilution, and then you will you will calculate the residual factor rate activity, which is compared to your control sample. So here in the above example, you got like this is in 1:16 dilution, which is which has a 44.7 of the factor rate activity, which is close to 50%. You select that, and you have the 90% factor rate activity in your control sample, and you correct that you calculate the residual factor rate activity in your 1:16 dilution sample. So you got it like 49.66% in your sample. So we assume that I told you that it's a type 2 inhibitor, but even then you assume like it will behave like the type 1, where you will see that there is 50% of the factor rate inactivation happens with the 1 Bethesda unit. So with this graph, you will calculate how much is the Bethesda unit, the inhibitor which is present in the sample, and then you will multiply by the dilution factor, you get the exact amount of the inhibitor in the sample. So here our dilution factor was 16. So, and we got the Bethesda unit as 1 from the graph. So with the total final, the Bethesda unit, I mean, the inhibitor amount present in the sample will be the 16. So whenever there is an increase in there are factors which might result in false positive results. Whenever there is an increase in pH and a reduced protein concentration, you can get false positive result. And also whenever there is a low titer inhibitors, less than 1 Bethesda unit inhibitors, your classical Bethesda assay can result in can give false positive results. So that's why you modify this test as Niemann modification, which will which can deal with these false positive discrepancies, and can give us it can be used when there is a low titer inhibitors. So how do you modify this Bethesda assay? So here, instead of in the buffer, you use the factor rate deficient plasma for dilution, and you use a buffered controlled plasma instead of the pooled normal plasma. So this will adjust the pH and the protein concentration, and so most of the false positive discrepancies can be dealt with, and low titer inhibitors also can be detected with the Niemann modification of the Bethesda assay. So this is the further test will be done like exactly like the Bethesda assay. Only the whatever the sample you have used is a factor rate deficient. The buffer for dilution, serial dilution you have used is a factor rate deficient plasma, and the other pooled, instead of the pooled normal, you have used a buffered controlled plasma. That is the only difference. Then you do the rest of the test like the Bethesda assay. So if your patient has received any factor rate prior to doing all these tests, then you can use a heat treatment. That is like you can heat the sample, plasma sample, at 56 degrees Celsius for 30 minutes and then centrifuge the same at 1700 for at least 5 minutes, which will which will inactivate the factor VIII, and further the detection of the inhibitor will be normal. So if your patient has received an emicizumab, if you are monitoring the patient after giving emicizumab, further monitoring, emicizumab is a bispecific molecule which acts like a factor VIII, which will cross-link the factor activated factor 9 to a factor 10, so which will act like a factor VIII. So your all your APTT based laboratory tests and assays are going to be affected. These tests, if your patient already has received emicizumab, these tests might give a normal results whenever, even if the patient has an inhibitor still present in the plasma. So whenever the patient gives a history of emicizumab administration, you are supposed to do the chromogenic assay to measure the factor VIII, and but you have to make sure that you use the bovine factors, factor 9 and factor 10, when you do the chromogenic assay, because otherwise the emicizumab can react with the human factor 9 and 10 if you are using those factors. So this is a graph which shows that with increasing emicizumab concentration, you will get an increase in the factor VIII activity and normal one-stage assay if you are going ahead with the normal one-stage assay. So here we can see that even if you are using a chromogenic assay, if you use the human 9 and 10 factors, activated 9 and 10 factors, still your factor VIII activity will be high and your APTT can be normal. But if you use a bovine factors, you will get at the exactly what is happening with the patient. So this is how you do a chromogenic assay. Here you use a bovine factors, the factor 9 and factor 10, activated factor 9 and factor 10, along with calcium phospholipid and the thrombin. And here you generate 10A with all these the factors. You generate the 10A, and the further test, you add a chromogenic substrate that the 10A will act on the chromogenic substrate and develop and leads to the formation of this chromophore peptide further. And you can assess the chromogenic the absorbance. If from the absorbance calculated, you can calculate the residual factor rate present in the sample, and then with this linear graph paper, you can calculate the exact amount of factor rate present in the sample. Thank you. For further approach and discussion part, I'll hand over to Dr. Akash.
Good evening, everyone. It's Dr. Akash here. Is the screen visible to everyone?
Yes, go ahead, Akash.
So just picking up from where Dr. Minu had initially spoken about the investigation as well as the follow-up of these patients. So I'll just go into the evaluation management. So acquired hemophilia A is characterized by neutralizing autoantibodies against factor VIII. It has low incidence and has two peaks, one in the pregnant patients and one above 60 years of age. In about half of the patients, we have a concomitant disorder which can be diagnosed mostly in autoimmune or a malignant disorders, and the bleeding can be variable in these patients. So in a congenital hemophilia, usually hemarthrosis is the most common way of bleeding, but in an acquired hemophilia A, it's mostly the subcutaneous bleeding, which is the common manifestation. Severe bleeding is seen in 70% of the individual, but mild or no bleeding is seen in 30% of the individuals. Now, while taking history and examination, we'll try to elucidate and rule out certain of the etiologies. As I mentioned, half of these patients will have some etiological disorder, immunological disorder like SLE or rheumatoid arthritis, obstetric causes. So post-pregnancy, postpartum, up till 1 year, there's an increased risk of acquired hemophilia A, AHA. Hematological and oncological causes are there. Pharmacological causes, antibiotics like beta-lactam antibiotics as well as clopidogrel is known to cause AHAs. Infectious complications like hepatitis B, C, COVID, as well as it can be a manifestation of chronic graft versus host disease in transplant patients as well. Coming to pathophysiology, Dr. Minu has already spoken about this. So these antibodies are non-complement fixing and non-precipitating IgG antibodies, and they follow second-order kinetics. Now, this is important for us to know that they don't have a linear correlation between the antibody titer as well as the bleeding. Hence, when you assess the treatment of these patients, rather than going by the antibody titer, we have to go by the clinical bleeding. Now, as I mentioned, 30% of these individuals would not have any significant bleeding, and they would have been presenting to us, for instance, as a pre-operative evaluation of an elevated APTT. So we will obviously try to do the factor assays as well and to rule out APLA in such patients. Now, the evaluation has already been dealt with. The trigger points are usually a prolonged APTT, which does not which does not correct on mixing, and a low factor 8 assay. Etiological workup also needs to be done to rule out autoimmune diseases as well as oncological causes and hematological causes as well. Now coming to the management, which is the important part here. So it is a two-pronged management here. First is hemostasis and second is eradication of the inhibitor. As I previously mentioned, there's no linear correlation between the inhibitor titer and the bleeding phenotype, and hence the clinical relevant bleeding has to be decided by the clinician as well. As we treat these patients, any hemostatic treatment, there's an increased risk of thrombosis. So that has to be borne in mind always while treating this patient. Also, I would like to ask the experts about the role of antifibrinolytics. I mean, there are some studies showing that use of tranexamic acid along with APCC causes increased thrombosis. So I would like to know their experiences of these experts in this. Now, regarding the part of treating, the initial part of the patient has a clinically relevant bleeding. The different bypassing agents that's available with us are recombinant factor 7A, the NOVA 7, APCC, and porcine factor 7. The APCC is given at a dose of 50 to 100 international units per kg every 8 to 12 hours, and it is monitored, and the duration is increased as the bleeding subsides. Activated factor 7, NOVA 7, is given at a dose of 90 to 120 mics per kg every 2 to 3 hours, again, when the bleeding subsides and the duration is increased. The pros of this approach is that it is already proven to stop clinical bleeding. But the cons is that we don't have any specific laboratory test to monitor the efficacy of this patient, and there's a thrombotic risk associated with both of these. There are some studies showing Tranexa along with APCC increases the thrombotic risk even further. In certain patients in which the Bethesda assay is less than 5 Bethesda unit, that is low titer inhibitors, a higher dose of factor 8 can also be used, but a trough level of factor 8 should be low so that we can balance between the bleeding and the thrombotic phenotype in this. Now coming to what we had used in our patient as well, emicizumab. So emicizumab has revolutionized the way in which acquired hemophilia A is being thought of as treatment. It is a subcutaneous administration. It decreases the bleeding, decreases the transfusion, and decreases the use of bypassing agent. So emicizumab obviously does not act immediately. The onset of action is between 2 to 7 days. But this is important to us because in some patients in whom we cannot start immunosuppressants at the get-go, we can use emicizumab prophylaxis in these patients to buy time because these patients might be sick, might have infections. In these patients, we can use emicizumab and the immunosuppressant can be started at a later date. Now coming to the second aspect, so once we control the bleeding, the eradication of the inhibitors. The importance of eradication of inhibitors has been known through historical studies which have shown that inhibitors associated with higher mortality rate of 20 to 64%. Now, with the advent of the bypassing agents, the death due to the bleeding has come down, but the death still remains to be high. The increased death is documented because of infection that is seen as part of the immunosuppression that is given. Hence, we have to balance the bleeding as well as the infection which comes from the role of immunosuppressive agents. The various immunosuppressive agents which are used in AHA are glucocorticoids, prednisolone at 1 mg per kg, dexamethasone at various dosages, immunosuppressants, cyclophosphamide and MMF, and rituximab, usual doses 375 mg per meter square for 4 weeks. But as I previously mentioned, there's increased infection risk in these patients. So in the era of emicizumab, we have to consider whether these immunosuppressant has to be started at the get-go or can we wait for some time. So that is based on the frailty of the patient, if the patient has any added risk factor associated with thromboembolism or not. Now, just consolidating whatever we've spoken. So based on a clinical presentation, patient has a bleeding phenotype with a prolonged APTT and an inhibitor being diagnosed. We diagnose an AHA. The initial bleed is treated with the bypassing agent that previously mentioned. Emicizumab can be considered as a prophylaxis if it's available, and whether the patient is fit or unfit. If the patient is fit, and then immunosuppressive therapy can be started either with glucocorticoids alone or glucocorticoid with a immunosuppressive agent, which can be cyclophosphamide or rituximab. This has to be monitored over a period of 3 to 4 weeks, and after that, if the response is inadequate, then a second line agent can be added in this regard. Now, regarding whether patients needs to be treated just with glucocorticoids or an addition of an immunosuppressive agent, this is the 2020 AHA guidelines, which mentions that if the factor 8 levels is more than 1% and the inhibitor is less than 20 Bethesda unit, then steroid prednisolone at 1 mg per kg might be sufficient in such patients. Patients can be followed up over 3 to 4 weeks, and if the response is inadequate, a second line agent added. But if the inhibitor titer is more than 20 Bethesda unit, then steroid alone is proven to be insufficient and a second line agent might need to be added. So in our case, the case one particularly, we had used steroid along with rituximab. Now, another treatment modality which is a popular, I mean, in a couple of studies in Hungary, I've mentioned about this alternative dosing called PSI-DRY, in which they're using dexamethasone, cyclophosphamide IV, as well as rituximab at a dose of 100 mg over 4 weeks. As I previously mentioned, that immunosuppression comes with its own complications of infectious complications, which has caused increased risk. Now, going to complication that arises from this is one of the largest studies done, included about 1,500 patients of acquired hemophilia A. And in this, they've seen that there's a risk of readmission within the first 30 days. Almost one third of the patient get readmitted with either a bleeding or one of the complication that I have mentioned. During the initial admission, obviously the first thing that present with is a bleeding, but there is an increased incidence of thrombosis during the initial admission itself because of the bypassing agents. Myocardial infarction was seen in 9.5% individuals, IC bleed in 1.5%, ischemic stroke, venous thromboembolism were also seen. Now, regarding mortality, 7% mortality was seen during the index admission, but a higher mortality, 10.8% mortality was seen during the readmission rates as well. And the commonest cause of readmission is infections followed by bleeding. So as I wind up my discussion, I would like to ask the experts the role of thromboprophylaxis in such patients. As we treat the patient and the factor 8 level increases, is there any role of thromboprophylaxis in these patients as well? Thank you.
Thank you, Chipsy and team, for this presentation and for the two cases that were discussed. I would request Joseph to take it forward with the Q&A.
Yeah, so I think they have covered, all aspects of acquired hemophilia to different presentations, the lab part and the clinical part well. And I mean, from the Q&A point of view, how often will you be? So Dr. Gohul, GJ has asked how often we will be able to identify an etiology for acquired hemophilia. You
So
want
I
to take?
think
Yeah, go ahead.
Akash has already mentioned, sir, that we might get a case of between one third to half the population. We might identify a case. Like in our, particularly these two patients, in one we didn't have any cause, even though there was a history of prolonged alternate medicines that he was taking prior to coming. That was one. And the other lady had a mild ANA or some positivity, but we couldn't document it. So less than one third to half only we'll get a case. But management principles remain the same irrespective of the etiology.
Unless you find a malignancy where it can be treated.
Yeah.
Um, Often we see this in postpartum patients, as you discussed sometime. And one question you had was an interesting question whether we'll end up giving anticoagulation in such patients. Dr. Biju, you have any case situations where you had to anticoagulate after having treated them?
No,
Lupus associated.
we've not had it with acquired hemophilia. We've had it with things like dysfibrinogenemia, which are prothrombotic, but acquired hemophilia, no. I think there was also a question raised about whether you would give things like tranexamic acid. Uh, so I think the use of tranexamic acid, yes, there is a risk of thrombosis, but then I think you have to go by how bad the bleeding is. For example, if it was something like a GI bleed, I would definitely use it, and we use it in clinical practice routinely. So there I would use it, but I have not had a situation where we had to do thromboprophylaxis. It's not going to be easy because generally, unless you've treated it well, most of the time the factor levels tend to drop along the way, and then you're going to have more problems. So, unless somebody's got definite thrombosis where you have to treat it, I would rather be on the fence, I think, in terms of saying let's do thromboprophylaxis. I would rather just treat a thrombosis. I had a question. So, what is the reason for considering emicizumab as first line therapy and not anything else? Because I'm not sure whether all the hospitals will have access to emicizumab. That's just a question. Are there anything else that you can use?
So thank you, sir. So the question was mainly because of logistics. So getting at that point in time a bypass agent and the costing of repeating the bypass agent was much more than we thought by giving a single shot emicizumab. That was one. And second, there was no IV access that we had for this patient. And there was this fear that he might be developing a compartment syndrome. So a subcut dosing was more influenced with the emicizumab. So these were the two reasons why we chose it. So, but the recommendation is obviously we can use a bypass agent factor, FIBA or factor 7. But if you do the costing, I thought for our patient that was beyond us. This worked out cheaper for us.
And I had just one more question. The first patient, I noticed that you had repeated the Bethesda assay and it had come down. Did you do a repeat factor level and see whether that sort of concomitantly came up? Because on your table, I think that was not there.
Yeah, so that was something that we wanted to highlight here because of this use of emicizumab, like we checked with Velor also, with Sukesh sir also we had checked. So he felt that we should not be doing it. This was more of to give us confidence. He said, wait at least 4 to 5 half-lives before you even try estimating the factor rate with your this clot-based
Routine.
test. So
No, yeah,
yeah,
But
that's the
I
so
problem.
thought your repeat level was done roughly about 2, 3 months
yeah,
after
so
the
we were
first
doing
one.
it for our confidence, sir, but
Okay,
he
okay.
strongly advised us
So,
not to do it. So that was also a
yeah,
learning
sir,
thing for us. Yeah.
if I may come in, I don't know any algorithm where factor 8 is checked. It is only a Bethesda units coming down is monitored. Just to share one of the experience, we had a similar situation of a pemphigus vulgaris patient, extensive associated with acquired hemophilia. And it was tough. Initially, we managed with FIBA alone because getting an approval from, I mean, he couldn't afford getting an approval from the government for the ME initially was difficult. So we had to put him as acquired hemophilia and sort of, he was acquired hemophilia, but then try to get it through the hemophilia channel because the word hemophilia is there. And we had to send him to civil hospital to get him through that to get ME actually 1 or 2 doses. That's how we manage. Other option is to give immunoglobulins if you have the option. But here he had two reasons where he had to get immunoglobulin was extremely immunoglobulin levels are also low in him. So anyway, these are all combination things will happen because of a secondary acquired hemophilia other than solid tumors or lymphomas they may have.
So one caveat I just wanted to add for all those who might be listening is that like in our case, if the patient goes on the emicizumab and goes and does an APTT outside, he might be falsely informed that he does not have any problem. That was a problem
Yes.
with us. So we had to prove it to him that he had a problem, and that is why we were trying to do these Bethesdas in between to show him that. So that misinformation can also be fatal.
Yeah. So you're absolutely right. Somebody getting high levels of factor rate, usually it will come as 200, 300% if you do a factor rate on somebody who has received emicizumab. So you're right. That's I think the take home there. If you do not have a two-stage assay, that will be a problem. Yeah. Any other questions? There's one more. No, there was only one question on the chat box. I think the speakers have covered so extensively that I think there's no questions left for people to ask. I think. Okay, so to Biju, any other experiences or anybody else in the audience who want to share
So
your experiences or difficult?
I have a young patient. He's about 25, 30, who presented with a thigh bleed and then found to have, he's about, yeah, 25 years old, found to have hemophilia, but he's had a factor 5, less than 1%, has antibodies. Uh, we treated him initially. We gave him, because he came in with a bad thigh bleed with compartment, we had to give him factor 7. And then after that, we gave him steroids, did not. So after we gave him the steroids, his factor 5 levels came up, the assays came down, but subsequently he's been difficult trying to control. Each time we come down on the steroids, we sort of find that again the levels drop. Also, clinically, he's not bleeding. He just does not have money for rituximab, so we are seeing how we can get it. So we give him some azathioprine. With azathioprine, again, he gets the levels come up, but then unfortunately he's from Bihar. He goes back, defaults on treatment, then comes back again. So we are sort of struggling with them. Only thing good is the fact that his thigh bleed or bleeds in any other areas have not resolved, but he's still sitting now with factor 5 levels less than 1%, with an APD sitting at about 60 to 70. So we are trying to see if we can get some rituximab for him and let's give him that. But I think multiple different factors. So I think we had a previous presentation on factor 13, Joseph, by one of the hospitals, acquired factor 13. So I think in clinical practice, we do see that going on.
Yeah. Okay.
Yeah, somebody else has said something.
Share. Any experience with acquired factor 13 deficiency? Yeah, that's it. Okay. So shall we wind up? We have only 8 minutes left. We'll give it back to Pratiksha. Thank you,
Yeah.
Chepsi, and the entire team, Dr. Akash, Dr. Minu, and Dr. Sudhir, for your discussions. And all the best for you for your future endeavors. Over to
Thank you.
Dr. Pratiksha.
As we conclude the 14th episode of Blood the Life Savior, we sincerely thank everyone who contributed to which making this initiative a continuous success. On behalf of Intas Pharmaceutical, I, Pratiksha Gullane, thank our esteemed faculty from the Believers Church Medical College and Hospital, Dr. Sudhir, Dr. Meenu, and Dr. Akash for their valuable insight. A special thanks to Dr. Chepsi for his excellent summary and concluding remarks. We also extend our sincere gratitude to our course director, Dr. Biju George and Dr. Joseph John, for their continuous and constant guidance. Finally, I thank all our viewers for their continuous support and participation. We look forward to meeting you all in the next episode of Bloody Life Savior. Thank you and good evening.
Right.
Thank you.